So what I'm doing, these little dots here, these little red dots represent the carotid baroreceptors, and here's the aortic baroreceptors. Now let's draw in some other things. This green area here represents the SA node. This is the AB node. And let's put the medulla oblongata somewhere up here. Make this pons, and the rest of this is medulla. Okay. Now, within the medulla, you have cardiac centers that influence heart rate, conduction velocity, and contractility. There are two divisions with respect to these cardiac centers. There's a cardioacceleratory center. And this is simply the sympathetic component of the cardiac center. And then there's the cardioinhibitory center. And this is simply the parasympathetic division. Okay. And let's say that mediating activity in these cardiac centers is that nucleus tractus solidarius. Now, afferent fibers from the carotid sinuses are going to pass into the nucleus tractus solidarius through the glossopharyngeal nerve. Which one is glossopharyngeal nerve? Cranial nerve 12? Nine. Okay. And then afferents from the aortic baroreceptors are going to pass into the nucleus tractus solidarius through what cranial nerve? The vagus, which is 10. Okay. All right, you might have to review this a little bit. Okay. Now, the cardioacceleratory center. Okay, remember this is the sympathetic component. This is going to send efferent fibers down to the SA node. Okay, these efferent fibers will release norepinephrine. Norepinephrine is going to bind to beta-1 receptors, beta-1 adrenergic receptors, to speed up the heart rate. You will also send efferents to the AB node, where there are beta-1 adrenergic receptors. Okay. These impulses will speed up conduction through the AB node. And it will also send impulses to the myocardium, okay, where there are also beta-1 receptors. And these impulses will increase force of contraction. All right, so sympathetic activity to the heart is going to do three things. It's going to stimulate the SA node, leading to an increase in heart rate. These sympathetic fibers are going to stimulate the AB node, leading to an increase in conduction velocity. In other words, the impulse is going to travel more rapidly from the upper chambers to the lower chambers. And then it's going to stimulate the myocardium, and that leads to an increase in the force of contraction of the myocardium. Again, all of these activities are mediated through beta-1 adrenergic receptors, receptors that bind norepinephrine from the sympathetic fibers. If you take pharmacology, we'll be covering this in pharmacology also.
I feel like we have.
We've started to cover it, but
But we haven't gone into that.
we'll cover it in more detail.
Dr. Boone, is the SA node, the AV node, and what's that last one?
And the myocardium.
Okay.
This is the myocardium.
So the conduction velocity would just mean like making the blood travel faster?
Yeah, I'll give you an example. When you look at an EKG, here's some EKGs. It's a series of waveforms. You have a little hump called the P wave, and it's followed by a spike called the QRS, and then a T wave. Now, I'm going to blow that up. So the P wave precedes the QRS complex,
Right.
which then precedes the T wave. The P wave represents depolarization of the upper chambers of the atria. Okay? Now, as that wave of depolarization passes from the atria into the ventricles, it's got to pass first through the AV node, where that wave of depolarization is slowed down. And there's a reason for that. It's so that the atria can respond to that wave of depolarization and contract before the impulse reaches the ventricle and leads to ventricular contraction.
Right.
We want the atria to fire and contract before the ventricles. So as that impulse is traveling through the AV node, we have isoelectric activity right here. The atria is contracted. Now, this isoelectric baseline activity is simply the impulse slowing down, traveling through the AV node.
Okay.
Once it reaches the ventricles, then we have this QRS complex. This represents ventricular depolarization.
Right.
And then finally, when the ventricles repolarize, when they reset so that they can conduct the next impulse,
The T.
repolarization brings about this T wave. Now, if you slow down conduction through the AV, or let's say you accelerate conduction through the AV node, you increase conduction velocity, that's going to impact this little time interval from the onset of the P to the onset of the QRS. This is called the PR interval. So if we accelerate conduction through the AV node, it's going to look more like this. You see the difference?
So it makes the time shorter.
Right, because this little baseline activity, this time interval shortens because the impulse, the wave of depolarization is passing more rapidly through the AV node, which separates the atria from the ventricle.
Okay.
Okay?
So it kind of goes hand in hand with the contraction.
Well, with what contraction?
Contraction of the atrium.
Well, contraction of the atrium is going to follow this electrical event, this P wave. Okay? And you're right. So it's during this delay that the atria are contracting. Okay, so now this increase in heart rate, there's a term that we use for this. We call this a positive chronotropic effect. In other words, when you increase the firing rate of the SA node, we refer to that as a positive chronotropic effect. It can be brought about by the sympathetic nervous system, as we're seeing here, but it can also be brought about by drugs that mimic the sympathetic nervous system. We say those drugs have a positive chronotropic effect. Increase in conduction velocity is referred to as a positive chromotropic effect. Positive chromotropic effect. It's associated with a shortening of the PR interval. Now, when we increase force of contraction, we refer to that as a positive inotropic effect. Positive inotropic effect. In fact, when you increase force of contraction, then with each beat, the heart ejects more blood. The volume of blood that's ejected is referred to as the stroke volume. So that a positive inotropic effect results in an increase in stroke volume. So in a setting where blood pressure is low, okay, then what's going to happen? This control center, the nucleus tractus solitarius, is going to stimulate the cardioacceleratory center. At the same time, it inhibits parasympathetic activity. Okay. By stimulating sympathetic activation of the heart, you're going to have an increase in heart rate and an increase in stroke volume. And if you increase both of these, that's going to elevate cardiac output. And remember, cardiac output is one of those factors that influences blood pressure. So as you increase cardiac output, then blood pressure comes back up. Everybody with me now?
Just processing.
What's that?
Just processing.
Yeah, this is a lot of stuff. Remember that these sympathetic fibers release norepinephrine, and norepinephrine binds to adrenergic receptors. It just so happens that within the heart, the subtype is beta 1. I think everyone's heard of beta blockers. Beta blockers would attach to those beta 1 receptors and block them from being activated by norepinephrine. So it would slow down the heart.
Those end in LOL, right?
LOL. Laugh out loud. Okay. Now, let's talk about the cardioinhibitory center. The cardioinhibitory center is going to be associated with efferent fibers carried by the vagus. Okay? And these fibers are going to travel to the SA node and the AV node. But there's no parasympathetic activation of the myocardium. So this is different from the sympathetic division. Parasympathetic fibers provide innervation to the SA node and the AV node, but not to the myocardium. What neurotransmitter do these parasympathetic fibers release?
Acetylcholine.
Acetylcholine. What type of receptor does acetylcholine bind to? Muscarinic. Yeah. So at the same site within the cells of the SA node that you have beta 1 adrenergic receptors, you also have muscarinic receptors that are there to bind to acetylcholine. Okay? So at these same sites you have muscarinic receptors, we'll abbreviate by an M. You're in the SA node, and also muscarinic receptors down here in the AV node, but none in the myocardium. Okay? So if you have increased impulses traveling down from the cardioinhibitory center, okay, releasing acetylcholine binding the muscarinic receptors, you're going to get a decrease in heart rate. And you're going to get a decrease in conduction velocity. So we could say that the parasympathetic nervous system, okay, triggers a negative chronotropic effect. And the parasympathetic nervous system slows down conduction velocity. That's a negative dromotropic effect. That negative dromotropic effect would be associated with a prolongation of the PR interval. said that the cardioacceleratory center is going to be activated in the face of a drop in blood pressure. On the other hand, if your blood pressure goes up, just the opposite occurs. In the face of high blood pressure, the nucleus tractus solitarius is going to inhibit the cardioacceleratory center, and instead it's going to stimulate the cardioinhibitory, the parasympathetic division. So that in the face of high blood pressure, you're going to slow down the heart rate, and you're going to decrease conduction velocity. Now, because cardiac output is influenced by heart rate, and here heart rate is slowing down, in the face of high blood pressure, your cardiac output falls. And if your cardiac output falls, that means your blood pressure is going to fall. Okay? So there's a yin and a yang happening here. If your blood pressure goes too high, you activate the cardioinhibitory. If your blood pressure falls, cardioacceleratory. Parasympathetic versus sympathetic. This is part of homeostasis. Maintaining a stable internal environment. Okay? So these are, what we've discussed up to now, are the cardiac centers. That influence the heart. Do you have any questions about this? Not tricky? Or do you feel like you have it? Okay. And let's matriculate.